Alright, so talking about ethical issue in cardiopulmonary resuscitation, and this is just a topic for discussion. Okay, what are the ethical issue you encounter during resuscitation?
Do not resuscitate.
Huh?
When to start CPR.
When to start CPR, when to stop CPR. Others? Huh? Do not resuscitate me. Okay. And okay. Another thing, the family requests to be with the patient during resuscitation. So we allow or not? Huh? Allow je. Agree, allow. Okay. So we are going to answer that at the end of this lecture. So there are multiple issues, and sometimes we don't have the same answer for all the scenarios. Sometimes the answers are different in between the scenarios. Okay, so these are when we talk about ethics, basically it involves legality. Legal. Your resuscitation, your notes are medical legal. Okay, so you have to write it properly and timely. Meaning that if you give your drug at 12:50, you have to write in your notes drug is given at 12:50, even though you write the notes later. Okay, so but you must be precise. So any question about the patient's right is depends on the understanding of the disease, the patient's conditions, the nature of the treatment, the alternative therapy, and risks and benefits. Okay, let's say example. There are lots of debating issues. Okay, whether to initiate CPR or not. But if you are working as a first liner, either in emergency unit or in clinic setting, sometimes you don't get the message because the patient will be brought to you at the level of unconsciousness, and you don't know the background history of the patient, and you initiate the CPR. You are not wrong. Okay? Only later when the family members arrive or when you have the documents, you see that patient is terminally ill disease. And then even the family members also agree to allow the patient to go. Then of course you are allowed to stop chest compression. Okay? But if you are working, but you must remember, do not resuscitate statement can be changed from time to time. Let's say you are working in a ward, and today you tell the patient that he's terminally ill, his condition might not improve, and we might need to CPR him later if needed. And let's say the patient said, "I'm refused. If my heart stop, please do not do chest compression on me." And that is a do not resuscitate statement. But at that moment, patient should be on the right state of mind, meaning that you must assure that patient is alert, conscious, probably with enough MAP to supply the blood to the brain. Okay, so in other way, patient in the right state of mind to make the decision. Okay, let's say you treat the patient, somehow patient improve, 2-3 days later, patient is improving, patient improving, somehow the next day, suddenly patient arrested. Do you CPR or not? Yes, you CPR because the consent for do not resuscitate me is based on his so-called your initial prognosis, and from days to days you saw the patient is improving. So you cannot use the day 1 do not resuscitate me, for the day 7, day 8, you must renew if it needed. Understand me? Okay. That is issue number 1, because sometimes I see many patients DIL informed. What is DIL informed? Actually, you're just telling the family members, you're just telling the patient, the family members, that your illness is very severe, you might die. But it's nothing to do with do not resuscitate. Death in line means death in line. It does not mean do not resuscitate. Unless when you say that your condition is very severe and the patient understood, okay, I know I'm going to die soon. If my heart stops, please do not do chest compression on me. Okay, that is do not resuscitate. So DIL and NAR is two different things. Okay, that is we have already covered few issues, and quite common issues is the family members request to be with the patient during resuscitation. What do you think?
Allow tapi allow at first and then give us sometimes to at least stabilize the patient, lepas tu baru kemudian berbagi tadi. Dia kalau time yang kita tengah coloured untuk stabilize patient tu, biar family members kat luar, and then later baru patient okay balik, suruh bagi dia masuk balik.
Agree, Mela? Agree. So bagi lah family members. Helmi tak bagi. Dia tak bagi
Sebabnya ada family members dia tak faham. So nanti apa yang kita buat, kita tekan dia masuk tube. So nanti dia akan salah faham.
Okay, so there might be some miscommunication. Dominic, any you will give at what stage? Tak kisah, bila-bila anytime. Whenever they want to see.
At least after intubation.
At least after intubation, yes. Why?
So intubation macam terlalu berat untuk kita tengok.
Berat? It's like macam movie movie berat, heavy movie. What do you think, Salin?
Ini masa resus patient, family nak masuk tengok.
You won't give. Sampai habis you tak bagi.
After finish resuscitation.
After finish resuscitation dah mati. After you declare death, then you bagi. Okay, you'll be surprised the acceptance, the acceptance of the family members. If you allow them to be with the patient during resuscitation, and at the end, patient succumb, somehow they will accept, because they saw you already did your best. So they will accept. As compared as, example, patient was brought in after developed chest pain while having morning breakfast with the family members. And they call 999, the ambulance rush the patient over here. They follow later, then they know what happening, and then suddenly you come out. I'm sorry to tell you that your father is already died. What is their response? Can you? Some of them become hysterical. Doktor tolonglah, doktor saya sembuh, doktor. Hey, I'm not God. Okay, so we have to give and take. Dominic gave a good point. Usually at initial phase of resuscitation, all the algorithm, all the steps are not really stable yet. Examples, patient arrive, you do hectic chin lift, then nobody is around, you call for help. It does not look good, because the family members will think that there's no staff in the hospital. Okay, so. And then sometimes, the chest compression, you take some time to get it rhythmically Okay, you need a few people around to help with intubation. And I think after 4 minutes or 2 cycles of CPR, we are quite settled. Meaning we already intubated the patients. So somebody is already taking care of the adrenaline every 3 minutes. Somebody is doing the bagging every 6 seconds. Everything is already in order. I think that is the best time for you to allow the family members. Okay, but before that you must tell the family members that their loved ones is at death in line lah, basically. And so only allow those with strong heart. You tell them that your loved one is intubated, we are doing chest compressions. If you want to be with the patients, are you really strong and willing to be with the patient? And you only allow 1 or 2 at one time. Because you don't want the family members more than the staff. Okay, and before the family members enter the resuscitation room, you must give cue to your team members. Sometimes your team members begging with one hand answering the phone. It does not look good. Everybody must look serious and give 100% commitment, even though you know the prognosis of the patient will be very bad. Okay, so that is some points how to handle the situation. It's quite common during resuscitation, but I still believe that the family members should be informed early. Okay, meaning after intubation, you tell the family members, oh, your father got a heart attack, a very severe one, he might not survive. And please do not give false hope. You tengok dah, the people is already fixed and dilated, but you tell the family members miracles do happen. Please don't use that word. You give the worst case scenario, at least if the patient survive or can, even though cannot do the daily routine activities, but if the patient survive, the family members will feel better as compared if you give false hope. Doktor kata ayah akan okey, tapi ayah makin teruk ni, dah nak mati lah. So I think you give at that moment what is the situation, what is the prognosis at that moment. And most of the time patient resuscitate is in bad shape. Alright. So any other question regarding ethics? Living will, the family member sometimes tell you that doktor, ayah ni dah cakap kalau jantung dia mati, jangan buat tekanan dada. But you need to ask yourself, number one, why the patient was brought to hospital? The family members mungkin will tell you just to confirm death. But number two, what is the nature of the patient now? And when you attach the current monitor, actually patient having VF, will you resuscitate? Will not you resuscitate? Will you not resuscitate the patient? Because the family members tell you, ayah kata kalau jantung dia sudah berhenti, jangan buat chest compression. Basically, when patient having VF, the heart some sort like stop pumping lah, just defibrillate kan. You must have some legal document because we are worried there will be some medical legal issues back. So don't involve in that. Dah 9 kau nak test 1, 2, 3. And then when you inform the family members, please get the correct family members, not the neighbors or the friend. Okay, let's say if the guy asks about his wife, okay, or if he is unmarried, ask about his parents. Okay, not the kawan-kawan. Okay, because medical legal kan, you cannot share patient information to everybody. Okay, any other issues? And of course, sometimes we have as young doctors, I pun kira young juga lah kot. Not more than 40. Belum 41 lagi, so not more than 40. Kan? Somehow we are so actively resuscitate. Example, patient 85 years old, fall in the bathroom, low level of consciousness. Because of the low level of consciousness, you intubate the patient. CT scan shows huge multiple bleeding, intraparenchymal bleed, huge with midline shift. And then patient become ready, and PEA, then you resuscitate. You must ask yourself, what is the quality of life? You have to discuss with the family members, okay? Because we see lots of family members who never go cuti Malaysia, and just because they have to take care of their relative who is bedbound. Itulah, kalaulah doktor tak selamatkan dia dulu, mungkin kita orang dah pergi Penang, ataupun pergi jalan-jalan Bali, kan? I mean, not just the quality of life of the patient, but also the quality of life people around you. Discuss with them, give option, but do not kill patient. Meaning you cannot. How bad the case is, you cannot off the ventilator, you cannot inject morphine or give more sedation. That called euthanasia. That's illegal in Malaysia. Alright, any other issues? So this is why not to start CPR. Of course, a valid do not resuscitate. Obvious signs of death. Of course, you don't know the duration. Datang-datang dah keras. You cannot open the mouth. So, you have the right not to stop CPR. When not to stop, these are conditions. If you have VF, you still need to continue resuscitating. I think my personal record with my team here is 90 minutes. We shock patient, shock drug, 90 minutes. So when it reached the 91st minute, patient asystole, then I stop. Because kalau continue, patient might get VM back, and we're going to continue for the second half, another 90 minutes lagi. So VF, you have to active, because you still have chance. Hypothermia per se in Malaysia is not uncommon, but drowning, we take as drowning. So drowning, you have to resuscitate longer, especially if it's a child. And you will so surprised that even the child has submersion about 20 minutes, you might still able to get the child back with active resuscitation. Okay, so when to stop CPR? Too exhausted to continue, meaning that if your team is small, if you are working in small clinic, only you and one nurse and one MA, you resuscitate already 30 minutes, 40 minutes, you feel exhausted because only 3 of you are doing CPR. You have been doing CPR for the past 30-40 minutes before, because you need to work and you have to look after other patients, then you have the right to stop. But there is no specific time, 30 minutes, and there's no specific time. Actually, it depends on from case to case basis.